I'm very pleased to be here today, and the Lundy family is to be congratulated for giving us this opportunity. Thank you. About 30 years ago, I found myself as part of the wave of deinstitutionalization, crammed into a private boarding home, private for-profit boarding home that had 70 people in it, all discharged from psychiatric hospitals, all pensioned off. And I frequently remember standing outside in the back. Someone had just jumped from the 3rd floor, and standing there and asking myself, what am I supposed to do? It helped being neurotic, so it was all my responsibility, clearly, to fix this situation. But I was at a loss. I'd come from Montreal. I knew none of the systems here. 3 months and 11 days in St. Mike's, and then into this psychiatric boarding home on a major intersection, King Dufferin. But few of us ever dared to be outside. I was fortunate, though I did not feel fortunate at all, but fortunate in that I got to know people. Joyce, your table is right there. Joyce? Now I'll embarrass the hell out of her. I was able to meet these people after my terror subsided, because people looked quite rough, as you can imagine, being in hospital that long. And the behaviors were challenging, to put it. Yeah, challenging would be a good way to put it. But I have to say, although I hadn't had a comfortable life or an easy life, this was the most shocking thing I'd ever seen. This many people jammed into bedrooms, and nobody coming in. It was astonishing. We could go months without anybody in officialdom coming by. And part of that was because the system really didn't want to deal with discharged psychiatric patients. So they would be totally discharged because of non-compliance. They'd been given an appointment card, but there were no phones, no calendars, no clocks available in the house, so time just went. So for about 30 years, a little over 30 years now, I've been working to answer that question I asked myself, what am I supposed to do about this? So I'll tell you some of the things that we've learned, and mostly because of listening to those who bore the burden of the isolation, of the old medications, of not feeling that they were valued at all by the neighborhoods in which they were, by the staff who sent them there. But over time, the first thing about advocacy is that you get really angry. And that can go on for years. There's nothing wrong with anger as long as it doesn't consume you. If you use it as jet propellant to get things done, that is good. But anger by itself accomplishes very, very little. So I had to learn to manage my anger, which I still am struggling to learn how. But one of the most uplifting events was Voices from the Street, which is a 12-week program offered originally to psychiatric survivors to teach advocacy, to teach how we impact policy, to show the kinds of things that were going on out there. And first group was good, lots of behavioral issues, but people were excited. Then we put them in with some folks with addiction issues, and that elevated the discussion in the group. And over the last 5-6 years, we've conducted groups at Toronto Community Housing. Hello. And there's some folks from that group here. We've done newcomers. We've done, but the point of that is that each time people would be around the table and there would be a mix. We learned that the best way is to mix people up. So we'd have people with maybe long mental health histories. We'd have people whose were newcomers whose credentials were not accepted, and they were getting emotionally crushed under the weight of poverty. We brought in single moms, sometimes second, third generation single moms on OW to talk about how that made them feel, how excluded, how blamed and stereotyped. And we started to have a very interesting effect. One of the reasons people stay crazy is that's all we know when we stay behind the walls that have been constructed. These new walls used to be in the institutions, and now it's in the community. So, you know, we call them silos, and these silos don't have windows usually. So mental health is here, addictions is here, newcomers are here. What I've learned is that when we separate people by diagnosis, we do a great disfavor to people and to their helpers, and to the general community. The more you think, and I went through this, my second book was called Dispatches from the Poverty Line, and it was a return to very acute poverty where I was in danger of losing my housing, and don't have the courage it takes to live on the street. So I started to realize how the impact of poverty and impoverishment mimics a lot of the symptoms of mental illness. But one really doesn't have to do with the other. So in talking to people with addictions, what got them starting on addictions, we were looking at violence and abuse early on in their lives. Newcomers, sometimes fleeing abuse from partners who were too stressed to be able to not strike out at their families. Started to see so many similarities between these generally separate silos. And the result of that is that you stop blaming the illness for all that's happening to you, because you see it happening to others who maybe never been in a psychiatric hospital, never had a diagnosis, so maybe there's something else going on here. When we use a really narrow lens to look at people, it distorts our vision so badly that we can no longer see that individual. We see an illness. And if we don't take the time to, academics use the word deconstruct, so let me try that. I'm never quite sure what it means, but if we deconstruct say the guy on the street corner who's yelling at people and dressed in really dirty clothes and not shaved for weeks, we look at that person and say, that's the face of mental illness. It's also the root of stigma and discrimination, because we look at that person and we say we're scared, we're frightened, we say, oh my God, isn't mental illness horrible? We avoid that person. So not being the brightest person in the world, it took me about 30 odd years to figure out, and not in a Marxist sense or in a communist sense, but what was going on here is that people who were poor, brought up poor, people who lived their lives without a net, whether it be a social safety net, which is a bit of a joke, or a strong family involvement that wasn't toxic. People who could, CAMH could put on a billboard for funding purposes and fundraising purposes to talk about how wonderful the hospital was. Meanwhile, we were being locked up in boarding and rooming houses and conveniently forgot about it. That was a great sin and hurt a lot of people. We also found out that our population, the chronically mentally ill population, died 25 years earlier than the average individual, which made things a bit more urgent in terms of getting change. When I was starting out, I was told by psychiatrists and government that we were doing ourselves no favor by expecting things from our community, and that we were actually jeopardizing their mental health, as if living 6 to a room, eating starchy foods, not seeing a medical doctor was not doing harm to people. When we do Voices from the Street, when we bring people together from those different silos, right away we expect. And when we expect, people live up to those expectations. We talk about institutionalized behaviors that may have protected people when they were in the institution, but now are effectively an anchor holding them back from growing. And we talk about the emotional intelligence to be able to sit in a room for 5-6 hours with other people and not get into arguments, not climb into a sandbox and kick each other and that kind of thing. We talk about expectations that people will do the work. We went to the Atkinson Foundation that used to own the Star. And one of the reasons we went there was because in the anti-poverty struggle or the mental health struggle, we often heard that our folks can't participate because they're too poor, and poverty, you know, the struggle to just keep your head above water means you can't really spend time in meetings and things. So instead of using that as an excuse to not involve people, we were able to pay people $60 a week for the 3 days that they attended, plus a hot meal from a social enterprise, plus a bus pass, which is gold in our community, so that people could sit at a table, not be hungry, not be worrying about what they could eat when they got home, not worried about their kids. They were freed up to be able to concentrate and contribute in our meetings, and consistently surprise themselves and each other in showing what and who we are. We're still doing that. We have to prove almost every day who we are, that, you know, when people come up and say, "My God, you're so articulate," you kind of wonder what they thought we were about. That's one of the things we may get T-shirts made. God, we're so articulate. Although I may be failing at that at the moment. We talk about in the group to show that this is difference, this is change, this is real. We bring people into a drop-in over which I worked. Our meeting room is over a drop-in, and a lot of the people who attend that drop-in are long-term psychiatric survivors who die maybe two times a month. There's another death, which is in keeping with the 25 years sooner than the general population. And I would have been part of those statistics, except that I had a quadruple bypass, so that eliminated my retirement plans so for growing old. And I let my folks know that it's no guarantee that you won't have to worry about getting old, guys. They have some very good, Clinton calls it the zipper club, right? Which is, okay. It was psychiatrists that were the hardest to reach when we talked about human potential and the wasted lives. And that's not surprising because psychiatrists, of course, had the most privilege and the most to lose from any kind of effort to balance the power that was out there. So here's a bit of learning. I was on the inaugural board at CAMH, Center for Addiction and Mental Health. I was appointed there because I'd been on the Clark board, put there by the NDP, who may have wanted to stick it to the guys at the Clark, I don't know. But there I was, a big chip on my shoulder, still working on keeping anger at bay. But it was a really good lesson because the community people sitting around that board, although they were bankers and real estate developers and lots of bankers and real estate developers, realizing that they were allies, and they became allies after I decided to try humor instead of scowling and talking instead of slogans. And they became really valuable allies to try and get change on the board at CAMH, which was, there was also, it was chaired at the time by a deputy commissioner of the OPP, which was also kind of nervous-making. Since then, one of my big rules is always go where they don't want you to be. Always show up where people don't really want you to show up, as uncomfortable as that might be. And one really good example of that is Civic Action, led by John Tory. I was asked to be a part of it about 4 years ago, and I hated going there because I just had my own mantra, elitism, 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 and God, I hate this. Then I was asked to be on the steering committee, which was a bit of a shock, and brought the director to Park, to Voices from the Street, to meet the women that were in that current group, funded by the feds, Women Escaping Violence. And meeting them, I know that Mitzi, who's the CEO there, just was shocked. Oh, these are poor people. These are the people we're excluding. 2 weeks ago, Civic Action arranged for our folks to present to Metrolinx on disability, poverty, and how fair isn't fair. If you take the TTC, that is the most grievous slogan that's come out so far, that when you have no money and you're trapped in your neighborhood. So our guys were really impressive, and as a result of their effort and their work, I'm going to be part of a bunch of business people, myself at a round table with the Premier in mid-April. So it's like you take a chance, you go where you feel you're not wanted, and certainly where you're feeling uncomfortable. And by reaching out and bringing your folks along with you to talk, it's a new thing for people to hear directly from the poor. In my time, there was a social worker standing, and I know there's a lot of social workers, and thank God you're here today, but, and I don't usually say that, but to be able to like our guys graduate at Toronto City Hall, and part of their graduation is they have to give a speech. And public speaking, though it comes easy to some of us, is supposed to be up there with death and moving. But they do it, and they do it bravely, and they do it well. And it's always impressive for people to hear them and see them, and they speak. You know, what we teach is speak the way people can hear. right? We teach those skills of how to talk to power in ways power can hear. It's quite annoying to have to do that sometimes, but the job of an advocate is to get change done, not to feel good about themselves or self-righteous or any of that stuff. We have a job to do as advocates. What we want, what we need, is to not just concentrate on one aspect of the individual. What we need is to start, I don't know, I think Deb Matthews called it a hub or something, to have a place of sort of one-stop shopping for all that ails you. You know, if you have a mental health label, you're probably also dealing with serious trauma that's affected your life. You are most certainly dealing with acute poverty that's affecting your life, precarious housing, and that sense, that huge frustration that your life isn't going anywhere. One of the things we talk about is nobody was put on the earth to be a mental patient or welfare recipient. You can do better. You can do better. You can control this thing called mental illness. You can manage your life, but you've got, CAMH calls it transforming yourself. We transform lives or something. Well, I spoke to Catherine Zahn last week, and I said some of us are stuck in that transformation. You know, you need to maybe revisit. I think we are a society that doesn't respect the poor, that has all kinds of negative judgments about poverty. When you combine that with addiction, when you combine that with mental illness or single parenthood or newcomers, we put huge weights on people and then wonder why they're not doing well. We fought to be able to speak for ourselves, not to have psychiatrists or social. Remember the old days when you would present a case history, so-and-so mother says, they have 12 siblings, they have. Now we talk about what we want to talk about. We highlight what we need to highlight. We use our lives as a tool to teach each other and to teach professionals about what we need to move ahead. We encounter really interesting resistance. You know, the mantra of the poor is supposed to be save our services, or we need more services. Well, we don't. What we need is for those services to be relevant, to be pragmatic, to share power with the people who attend. We have a lot of little fiefdoms out there, whether it's supportive housing, which isn't. One of the saddest things is, you know, when we got out of hospitals, where the worst aspects were that you had no control over when you ate, when you slept, when you bathed, when you got outside for a smoke. Now, having escaped that environment, we're out of the frying pan into the fire, where excessive control and manipulation and powerlessness have been recreated in the community. And what that's done is to stall people's lives once again, right? I call it plateauing, like, oh my God, I have a roof over my head, I better not risk anything else. And all the staff around you are telling you, don't risk anything else. One of the good things that the Mental Health Commission has been doing is to actually track discrimination and prejudice within frontline and up workers towards the mentally ill. It's not something you'd expect, and I don't think it's cruelty-based, but it's people looking at people in pain and saying, "Oh my dear, we take more medication," or "Don't go to work today," or "Don't do this." And it essentially cuts the legs out from under people who need a gentle push, who need applause in the background to, you're taking the right steps, you're moving forward. The right to risk is probably the most important right any adult has. And that's been, in too many ways, taken away from us. On the other hand, the stuff that we've been, I want to talk about RACI, which is an odd term, but it's 5 years ago now, and this is why it's important to stay open and stop snarling at people when you're trying to affect change. I was approached by 2 female psych residents, so they already had their medical degrees, but now it's like 5 more years to be a psychiatrist. And they'd heard one of our speakers and came to me and said, we're not hearing what you folks are saying in our first year curriculum. Maybe we have to develop an underground curriculum. So putting aside my immediate suspicion, which was rampant, we had the first meeting in the Voices boardroom. Psych residents, first year psych residents looking very scared, like we were going to denounce them, or which we didn't, because we've learned how to talk to power in ways people can hear. That first meeting, as uncomfortable as it was till the food arrived, did start to break some ground, and especially broke it down when a young man, Andrew Howlett, who's now a shrink at St. Joe's, said, why don't we meet at my house next time? Now, old-time crazies and old-time stuff will probably react the way I did, which is, oh my God. This is amazing that he would say that. And we have continued to do that over 5 years. Now, the people we bring from Voices are people who aren't going to say, this is my life, how terrible, or stalk a psychiatrist or do all that. These are people who will engage, who will talk about things like the curriculum that they're learning. You know, we talk hard talk, we talk about CTOs, we talk about shock treatment, we talk about forced medication. And we do it collegially, because we're trying to teach each other. For me, this has been mind-boggling for the whole 5 years, because you know, I started my psych career at the age of 18, and I'm constantly shocked at some of the new learnings that are going on. I'm very, very proud of that. Because of our association with the baby shrinks, as we call them, and we don't know what to call the baby shrinks who graduated. That'll come up, I'm sure. But we've been working, like I will bring them to police meetings, where mostly we don't have psychiatrists on that police subcommittee. We have a lot of people with direct experience, and Alok Mukherjee, who's the head of the police board, co-chairs with me, and we've got a lot done, including helping with a video where our folks are talking about what works when the cops come to the door to take you in and what doesn't, and how to keep both police and survivors safe during a fraught time. Aside from RACI, the second most exciting thing is, because again, coming from the chronic patient community, is working with Kwame McKenzie, psychiatrist there, and the Empowerment Council at CAMH, in introducing the notion of recovery, which was not in the curriculum for chronic patients, and actually getting rid of the term chronic, because that'll close down any efforts. I think we're taking the lens complex patients, and because we like to be complex, so I think that's going to be the new term that we use. So it doesn't shut the door to the possibility of recovery and change. So we sit there and we bring in people from the DREAM team, we bring in people from the Empowerment Council, and work with third and fourth year residents who are doing their chronic tour, whatever that's called, So they hear from us first, and then there are breakout groups where we co-facilitate with a working psychiatrist or psychologist to say this would work, this wouldn't work. So these are profound, profound changes in our system. The next big thing, of course, is going to be ODSP, or as we call it, ODS, the Ontario Disability Supports. I will close with just reading you one thing I prepared for ComSoc. And ComSoc is saying that ODSP is no longer sustainable in the amounts that people are getting on it. So, and it's the mentally ill who are on it the longest and never leave. So I was trying to think how I could explain to the assistant deputy at ComSoc why this was and how we could work. So I'll just read you that. My experiences with those who are labeled seriously mentally ill with schizophrenia, manic depression, and PTSD, as well as those with long-term addictions to drugs like crack cocaine. In this group, poverty is the norm. Days are spent in drop-ins or waiting in packed agencies for assistance that never seems timely or appropriate. These aren't people who can hide the toll taken on their bodies, spirits, minds, and hopes by years of exclusion, dependence, and otherness. They are carrying with them some of the most debilitating features of institutionalization, begun in the hospitals they found themselves in, and continued in the community and the agencies responsible for their care. The tale of community mental health, supportive housing, and drop-ins is one of missed opportunities and failure to recognize and tap the human potential all around them. Why does this matter? People have had mirrored back to them their inability, vulnerability, and incapacity in almost all areas of their existence. The worst aspects of hospitalization, the lack of personal control over the simplest activities, from bathing to meal preparation to socialization, the inability to affect the rules and regulations governing them, the overly narrow lens used to define who they are and what they're capable of, the refusal to recognize and address the impact of poverty, isolation, and the social determinants of health ensure a broken population will remain that way. People who suffer from an excess of powerlessness cannot imagine a self-directed life. It's not the same as feeling unwell, seeing a doctor, getting a diagnosis of diabetes, along with a roadmap for how to cope and integrate the illness into a productive life. For the SMI population, a label of schizophrenia or mood disorder feels like an ending to their story. They watch as friends drop away, their status in their family radically changes, and they feel as though they are permanently blocked from achieving the goals and dreams they've held since childhood. Undoubtedly, their experiences in school and their attempts at work have been dreadful and scarring. The general public does not do well with difference, especially since stereotypes of the mentally ill emphasize potential violence and bizarre behaviors. For the individual who may have endured frightening episodes of psychosis, being constantly warned rather than supported in what is viewed as risk-taking, such as returning to school or taking up work, ensures the person is kept dependent, pensioned off, and discouraged from achieving. As a community, then, one which struggles to be seen and heard for all they are, we are learning that empowerment, engagement, and continuous learning are critical to growth. Without the ability to affect the programs that govern them, see themselves reflected on staff and boards, they have no sense of their own value as active participants in recovery. Rather than being a safe place to experiment with autonomy and involvement, voices are silenced and stilled. Even those who purport to fight for our needs fail to understand the long-buried dreams of this population. Charities ask only for an extra food allotment. Services declare more of the same are needed. We don't hear a whisper about the need to require better outcomes, to redirect agencies from simply controlling their clients to making them true partners, hiring role models to challenge negative assumptions held by staff and clients, and profiling their successes. We've made significant strides in the seriously mentally ill community with social enterprise, leadership development. We're speaking for ourselves, to government, to police, to CAMH. The only sector that stubbornly persists in excluding our voices or relegating us to advisory roles is community mental health, where power is jealously guarded and kept out of our hands. Both the Human Rights and the Mental Health Commission have related how prejudice and discrimination is firmly seated in our helpers. This must be righted. We are the government's natural ally in this fight. We are tired of the stress of living impoverished lives, tired of being surrounded by well-meaning naysayers. Without substantial change in the attitudes of our helpers, without making room for us as equal participants, the numbers on ODSP will continue to rise and much potential will never be realized. Thank you.